Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator.
But we're thankful. This is our first webinar series for the year, and we do have Dr. Alkanderi with us today, who will be treating the restoration of one dentition. Dr. Alkanderi was born and raised in Kuwait. He attended Virginia Commonwealth University, where he received a Bachelor of Science in Biology degree in 2012 and a Doctorate of Dental Surgery degree in 2016. Following his completion of his dental degree, he moved back to Kuwait, where he completed an internship in advanced education in General Dentistry in 2017. Dr. Alkanderi is currently a third-year post resident at the University of Texas Health Science Center at Houston. After his completion of his postgraduate training, he will be joining Loma Linda University for a one-year fellowship in implant dentistry. Thank you so much, Dr. Alkanderi, for your willingness to participate in this webinar series today. And bear with us, we do have a couple of technical issues with this presentation, but I think we're going to be okay. We're going to be okay. All right. Anyway, so if you are logged on, thank you so much. I appreciate it. Please do mute your phones, and if you want to, mute your phone so that we can have a smooth recording today. So Dr. Alkanderi, please go ahead and share your screen.
Okay, I'll go ahead and do that. Okay, perfect. Again, good morning, everybody that's watching this webinar from here in the United States, and good afternoon to those watching this lecture from Africa, and Happy New Year, everybody. Thank you, Dr. Uvoh, for giving me the opportunity to present this topic and present one of my cases today. So again, I will start by introducing myself. I'm Ahmad Alkanderi. I'm originally from Kuwait. That's where I was born and raised. So after high school, I secured a scholarship from the Ministry of Higher Education in Kuwait to study dentistry here in the United States. And in 2008, I came to Richmond, Virginia, to do my undergraduate studies and my dental education at Virginia Commonwealth University. And after dental school, I moved back to Kuwait, and I did a one-year internship in advanced general dentistry before getting accepted and joining the postgraduate program here at the University of Texas. Currently a third-year prosthodontics resident. So the topic of my presentation today is the restoration of the worn dentition. The incidence of tooth wear has increased dramatically in the last several decades. So in your practice, if you see patients that are in their 50s, 60s, or above, perhaps 20% of those have severe wear into the dentin of their teeth. So we from research that minimal tooth wear is a normal physiological process that occurs to all of us. And it's measured that enamel, which is the outer layer of tooth structure, wears at a rate of 10 microns annually. But excessive tooth wear can be pathologic and can lead to multiple problems, such as pulpal problems, can impair function, and can lead to aesthetic problems as well. So we know that wear is a form of an occlusal disease, and according to Lytle, occlusal disease is defined as the process that causes damage to the chewing surfaces or occluding surfaces of teeth. And it can be attributed to multiple issues, such as being the most common destructive dental disorder, being the most common reason why teeth need extensive restorative therapy, and a very common reason why teeth go symptomatic or become hypersensitive, leading to unnecessary endodontic therapy. So when we're trying to diagnose the loss of tooth structure, we have to think about the etiology and how the patient got to this point. This is a great reference by Dr. Verrett in San Antonio that explains the patterns of wear and how we can relate these patterns to the etiology. So what I want to share with you today is some of the causes of tooth wear. So you would have the confidence and knowledge when you're talking to your patients about some of their indecisions or their lack of knowledge about what's happening. Oftentimes, when we tell our patients that they have tooth wear, they take that as a punitive thing, as if they've done something wrong, but that's certainly not the case. So really, we can break the causes of tooth wear down into two main categories, chemical and mechanical. First, I will address mechanical causes. So physical or mechanical causes could be related to attrition, which you and I would know as teeth grinding. So when teeth rub against each other, we call that attrition, and that's one factor or one reason of tooth wear. The other physical cause of tooth wear is abrasion. Abrasion is in fact something abrasive that is causing tooth wear. Abrasive toothpaste, for example, can produce abrasive tooth wear. An old porcelain crown, which is highly abrasive, can cause tooth wear. So when we use the term attrition, what we are really talking about here is that the patient is moving their jaw and that the maxillary and mandibular teeth are rubbing against each other. So we see in this particular instance, this is my patient, and when she moves her jaw to the left side, we can see that she has a significant amount of wear on her upper and lower teeth. So when we think about attrition, the key to that is that the mandible is moving. So the question here, why is the mandible moving? Patients don't wear their teeth out from attrition unless the mandible actually is moving to left, right, forward, or a combination of all of those positions. So that brings us to theories of about why attrition occurs or why attrition happened. So there's fundamentally three theories about attrition and why teeth would run into each other and why would they produce tooth wear. One theory is what we would call the functional theory or functional etiology. And it basically says that some patients wear their teeth out under normal function, that's chewing. And we know from the work of Landin and Gibbs back in the 70s that patients that have all their dentition, they don't wear their teeth during normal function. On the other hand, there are those patients that have grinding patterns of chewing, in which they close, they move their jaw sideways, and then they open. And that is commonly evident in those missing their posterior teeth. So what we know from that is that those patients who lack their posterior teeth or they're missing their posterior teeth in the maxilla and mandible actually in fact have more tooth wear. So it looks like there is some relevance to this functional theory. The second theory about why patients grind their teeth is occlusion or occlusal etiology, very common through the 40s, 50s, 60s, 70s, 80s, 90s, and the concept being that if your occlusion does not fit correctly, it can in fact produce tooth wear. So if we look at the skull on the right-hand side, the bite appears to fit just fine, but when this patient's mandible goes back into a seated position, the bite does not fit fine. And the theory would be that this discrepancy between the seated position and the habitual position causes the patient to grind their teeth back and forth. Nowadays, most research looks at grinding and relates it to Brexism. Brexism is actually a central nervous system event. When the sympathetic nervous system is activated, that activation activates your heart rate, your respiratory rate, your brain activity, and ultimately, in some patients, they grind. So today we know that, in fact, this is probably the most prevalent cause of attrition. Also, we know from research that there are links between Brexism and airway obstruction, and that topic is discussed or studied extensively by Jeff Rouse. We also know that there are links between Brexism and gastric reflux, links between Brexism and some psychological or neurological conditions. So the importance of that is that the old way to think about this, that if we corrected the bite, we can get people to stop grinding. But the new way to think about that is that people are going to grind their teeth no matter what. And what we have to do is to protect their teeth. And if we restore their teeth, we have to do it in a way that our restorations survive their grinding. How do we achieve that? How do we do that? By interpreting their patterns of wear and designing our restoration or designing our occlusion accordingly by distributing the force over the teeth that are bearing the load in this case. So now that we have gone over the physical causes of tooth wear, theories about attrition, the second cause of tooth wear is not physical in nature. It's not rubbing of teeth against each other, but in fact, it's chemical, it's erosive. According to the glossary of prosthodontic terms, erosion is defined as the loss of tooth structure by a chemical process. What actually happens here is a process called perimyelitis, in which acid, such as stomach acid, acidic beverages, Coca-Cola, energy drinks, Gatorade, citrus fruits, demineralize or weaken the outer surface of the tooth. And that weakened surface is actually abraded away by the action of the tongue, cheeks, lips, toothbrush, foods, and etc. So when we think about erosive tooth wear, we have to think about where the acid comes from. And acid actually comes from two places. It can either be extrinsic or intrinsic. Sorry, it can be extrinsic or ingested acid, where the acid comes from the front. And the place where the acid comes from is intrinsic or regurgitated. And that acid comes from the inside. And where the acid comes from affects how the teeth look like. So we can have ingested acid as in acidic beverages or carbonated beverages. And typically ingested acid produces tooth wear on the facial surfaces and on the occlusal surfaces of teeth. And because that happens while patient's head is upright, gravity tends to pull the acid or the acidic beverage on the lower teeth. And for that reason, you may see more wear on the lower arch compared to the upper arch. Intrinsic or regurgitated acid, typically think of that as gastric reflux or any other eating disorders such as bulimia. Usually the acid shows on the palatal surfaces of the maxillary anterior teeth or the occlusal surfaces of the maxillary posterior teeth. Also, that acid or the presentation of the intrinsic or regurgitated acid could be asymmetric. And the reason for that, because gastric reflux actually happens quite commonly while people sleep. And if they are sleeping on their side, on their left or their right, gravity pulls the acid to one side or the other, causing that presentation. So if we are to classify the most common causes of chemical erosion, we have gastric acid. Eating disorders are very common in our culture here in North America. Also, we have acidic beverages. Fruit sucking is incredibly common in some of the country, and acidic beverages are highly abused by lots of people of all age groups. So just to give you an example of how it looks like when you see a patient with a lot of tooth wear, like let's say this patient presents to your office with a lot of tooth wear. This is a classic example of a patient with gastric reflux. We can see that the maxillary posterior teeth are devoid of enamel on the occlusal surfaces, and the maxillary anterior teeth are missing enamel on the palatal surfaces. So the presentation of that patient or the wear pattern is that they have shiny surfaces and the occluding surfaces do not fit together, and they have what's called elevated restorations, and in this case we have amalgam islands. Also, the more common ones along with gastric reflux is acidic beverages. Acidic beverages can be in two different ways. One way is by drinking the acidic beverage, swishing it around, and then letting it sit in your vestibule. And we call that soda swishing. And that pattern of wear presents itself on the cervical portion of the maxillary anterior teeth or the mandibular anterior teeth, similar to what we see here. The other way of abusing acidic beverages is that you drink the acidic beverage and you let it sit on your bottom teeth. And we call that acidic beverage pullers. And those patients actually have a very interesting wear pattern in which the mandibular posterior teeth exhibit tooth wear only. This is a patient of mine that upon interviewing him, he admits swishing with Coca-Cola and sucking on lemon. So we can see that the islands of dentin in the cervical portion of his maxillary anterior teeth. So generally speaking, when wear happens, enamel will eventually wear away and it will perforate, and then it will hit dentin. And we know from literature that dentin abrades away or dentin erodes at a much, much faster rate compared to enamel, measured at about 25 to 29 more times compared to enamel. So we know that erosion happens in nature and shapes our planet. This is a picture that I took at Antelope Canyon in Arizona. And actually, this canyon was formed by erosion due to flash flooding of rainwater and other processes. I just found that interesting. So now that I talked about the etiology of tooth wear, theories about attrition, let's switch gears a little bit. So what I'm going to talk to you about here is different patterns of wear that occur in different patients, and the nature of the treatment that is necessary for each pattern of wear. So fundamentally, there are three patterns of wear that occur very commonly in people or in our patients. And the pattern of wear, how the wear presents itself, affects the treatment that is rendered in order to solve that problem. So we will start with actually a very common pattern, or probably the most common pattern that we see, which is a patient who has more anterior wear than posterior wear. So the fundamental problem here is that there is no wear whatsoever on the posterior teeth, which is actually a good thing. That means that the bite is maintained and the occlusal vertical dimension is maintained in this case. But as the anterior teeth wear away and they get shorter and shorter, they don't just sit there. In fact, what they do instead, they erupt down to maintain the occlusion. So the challenge here, if this patient comes to your office with very short front teeth, very short, attractive anterior teeth, and they want to have these restored because they want them to look better. But the problem is that there is no room to place these restorations. So at first, it looks like the bite will need to be open in order to create room to restore the anterior teeth. But in fact, when we have what we call segmental wear, as we see here, more anterior teeth than posterior, more anterior wear than posterior wear, we normally don't need to open the bite. What we need to do here is to correct the eruption. So for the patient, what we can typically do to correct the eruption is either orthodontic intrusion, periodontal crown lengthening, or sometimes segmental orthognathic surgery. So what that does, that takes the teeth that have erupted into the incorrect position and put them back into the correct position. Okay, so now we have the room to restore the anterior teeth that are worn. So in this case, we end up restoring the teeth without doing anything, or we end up restoring the anterior teeth without doing anything to the posterior teeth. So that would be an example of using orthodontic intrusion to take the teeth that have moved into an incorrect position and put them back. So a good strategy for this type of wear, halfway through the treatment, you instruct your orthodontist to remove the brackets, and you build the anterior teeth to normal length, central incisor being 10 millimeters, and then send the patient back to rebond the brackets and fine-tune the gingival margins and tooth position. Also, composite here can be a good phasing tool. It can help the patient to gather their finances before they move to the durable ceramic restorations. They can keep the composite for a couple of months to a year. It will also allow you as a clinician to test drive the occlusion and make any alterations to the occlusal design that is needed if the patient exhibits any chipping of these composite restorations. So now the opposite pattern of wear, which is more posterior wear than anterior wear. And that can be seen commonly in patients with gastric reflux. Same as before, the occlusal vertical dimension in this case is maintained because there is no wear whatsoever on the anterior teeth. But again, when the posterior teeth wear, they do not just sit there. Instead, what they do, they erupt down to maintain the occlusion. So now you have short little teeth that end up in occlusion together, and you want to restore these teeth for any reason, but you can't because these preparations will not resist any dislodging forces in the lateral position or in oblique or any oblique forces. So this is an example of a patient with gastric reflux. Look at how short his posterior teeth are. There's no way that you can prepare the posterior teeth 1 millimeter or 1.5 millimeters. There will be nothing left of it. So you either have to do, again, as before, orthodontic intrusion, clinical or periodontal crown lengthening, or segmental osteotomy. But remember, if you're trying to do a functional crown lengthening to make the teeth look longer, you have to evaluate the periodontal status, you have to evaluate crown to root ratio, you have to evaluate the length of the root trunk. You don't want to proceed, or you don't want to go with that route and end up violating the furcation in the posterior teeth. So the correction for this patient would be to orthodontically intrude the teeth. And in this case, the orthodontist can use mini implants apical to the posterior teeth to put them back in the correct position. And the mini implants will allow the orthodontist, or will provide him with, so they can put the teeth back in the correct position. Again, as I said, half the way through the treatment, you can remove the brackets, add composite restorations to build the teeth back in. You can either restore them with full coverage restorations, as what I did here, or you can do partial coverage or just occlusal coverage, which will be a very nice and conservative way for these patients. And the last pattern of wear is wear on anterior and posterior teeth. And those patients do need to have their entire mouth treated. So if the rate of tooth wear exceeds the rate of eruption, the bite will likely collapse. And how does that happen? It happens if there is a process that accelerates the wear. We call it facilitated wear. If there is an acidic component and if the patient is Bruxer, that is likely to happen. So when we're evaluating those patients from the extraoral view, they look edentulous and they do not show any teeth at lip rest. So what we have to do is to reestablish the occlusal vertical dimension and restore all their teeth. Okay, the question here, how much do we need to open their bite? Where do the teeth go? I will answer all these questions in the next part of my presentation, which is a case that I completed for one of my patients here in residency. So this is my patient, TK. He's a 71-year-old Caucasian male. He's 5'11", 225 pounds. His medical history is non-contributory. He does not have any illnesses or take any medications. So I classified him as ASA class 1. His dental history is quite extensive. I actually had this patient transferred to me from one of the previous residents that graduated, and he had a lot of work done before I started seeing him. He had multiple extractions, periodontal crown lengthening, bilateral sinus augmentation, and implant placement in the posterior maxilla bilaterally, endodontic treatment on his mandibular canines, number 22 and 27, and finally a insertion of interim RPD at the proposed occlusal vertical dimension. So when he presented to me, his chief complaint was, I had implants placed and gum surgery done. I'm here to continue my treatment. So this is the frontal view, and we can evaluate his normal smile or his social smile on the left-hand side and his exaggerated smile on the right-hand side. And in this close-up view of his smile, we can see that he shows about 50% of the maxillary anterior teeth, and also he has a low smile line. He does not show the gingival margin of the maxillary anterior teeth. But in this repose position or this lip at rest position, he does not show the incisal edges of the maxillary anterior teeth. And for that reason, I am going to plan my provisional restorations to extend just below the resting lip. And according to Vig and Brando from classic denture literature, we know that patients in this age group, they show about 1 millimeter of tooth or incisal display at lip rest. So this is his retracted anterior view and maximum intercuspation. You can see that he has thick gingival phenotype, multiple missed teeth, I would say generalized supraeruption, and wear or loss of tooth structure on the facial surfaces, incisal surfaces, and the occlusal surfaces of his teeth. This is the maxillary occlusal view, and we can see the implants in sites 3, 5, 12, and 14. PFM crown on number 6, and significant amount of loss of tooth structure on the maxillary anterior teeth 7 through 11. The molar implants are Nobel replaced conical connection, 5 millimeters in diameter by 10 millimeters in length, and the premolar implants number 5 and 12 are 4.3 millimeters by 10 millimeter in diameter. Sorry, 10 millimeter in length. This is the mandibular occlusal view, and we can see that he has large mandibular tori bilaterally. He has multiple missing teeth in the mandibular anterior area and mandibular right posterior area. So we can see alveolar ridge keratosis in the mandibular posterior region on the right side, amalgam tattoo around number 19, fractured porcelain number 19 and 20, and we can see that teeth number 22 and 27 are endodontically treated with composite obliterating the endodontic access. This is the right lateral view in MI, and we can see that, or the supraeruption that happened to the mandibular posterior teeth, and the lack of restorative space in that area. Similarly, this is the left lateral view, and we can also appreciate the supraeruption of the mandibular posterior teeth and the lack of restorative space to accommodate for my restorative material. So his periodontal status has a good prognosis. The probing depths range from 1 to 3 millimeters, except one area on the mesial of number 18, measuring 4 millimeters. There's no significant findings in the maxillary and mandibular anterior periapicals. We can see that teeth number 22 and 27, the mandibular canines, are endodontically treated. In the posterior periapicals, we can see in the maxillary posteriors, we can see the implants with good marginal bone levels around these implants. Tooth number 19 is endodontically treated with prefabricated post in the distal canal. So now that we have reviewed all the significant findings, we have to formulate our diagnoses in order to come up with a treatment plan for this patient. In PROS, we like to start with the prosthodontic diagnostic index, and since this patient's occlusal scheme is severely compromised, that automatically puts him in class 4, which is the highest classification of the SPDI classification. Again, back to this reference, analyzing the etiology of the extremely worn dentition. The patterns that I found in this patient are what you see here, and what I concluded is that he has parafunctional habits such as Brexism with an acidic chemical component that is exacerbating his tooth wear. Also, the diagnosis of wear can impact the occlusal vertical dimension. This is a great reference by Dr. Turner that allows us to diagnose the patient in relation to the loss of occlusal vertical dimension. So I classified him as, or I put him in category 2, excessive wear without loss of occlusal vertical dimension, and that is due to continuous eruption, that's what I believe, without available space, and the space can be gained by repositioning the patient in centric relation, and there's insufficient space for the restorative material, and for that reason the occlusal vertical dimension will be established. So the treatment plan for this patient, or the treatment plan that he accepted, involves in the maxilla implant-supported fixed prostheses on the maxillary posterior regions bilaterally, single crowns on 6 through 11. In the mandible, it involves single crowns on 19, 20, 21, 28, 29, treating the mandibular canines with cast posting core and placement of a 6-unit fixed dental prosthesis to replace that missing area in the mandibular anterior region, and eventually implant in site number 30. So now I will go over the sequence and the steps that I followed treating this patient. So before the start of the treatment, I gathered all the diagnostic information and I performed a full mouth digital wax-up. And then a mock-up was done intraorally in order to determine incisal addition, aesthetics, phonetics. Basically, what I wanted to do is get the teeth in the correct position aesthetically relative to this patient's face, and that will allow us, or that will tell us how much we need to open his bite. Basically, it's addressing or targeting this case in a facially generated treatment planning way. So the next step would be to test the new occlusal vertical dimension. What I wanted to do is to place provisional restorations on the maxillary posterior regions, to place implant-supported provisional restorations, to test his new position, to test how he's tolerating the new position. So what I did, I made an implant-level impression using an open tray, and then the master cast was generated. And we see on the left-hand side, the master cast, I trimmed and manipulated the gingival moulage there in order to develop his profile in my provisional restoration. So in this case, because I was mainly or solely relying on these provisional restorations or provisional FDP to test the occlusal vertical dimension, the new occlusal vertical dimension, I wanted to use a material with high flexural strength. In this case, I used Radica, which is a laboratory composite material by Serona Dentsply, which has a flexural strength higher than jet acrylic and bisacryl composite, and its flexural strength measured at 160 microns. So the provisional restorations inserted in the maxillary posterior regions, and then I allowed the patient a period of 8 weeks in order to, again, to test his tolerability to the new position. And I made sure that he did not develop any temporomandibular joint symptoms, no clicking, popping within the TMJ, no myofascial pain. And when I confirmed that, I was comfortable to move forward with my plan. So the next step was to prepare teeth number 22 and 29 for cast post and core. And then the canals for the mandibular canines were prepared, and I made an impression of the canals or the post space to fabricate the cast post and cores in the laboratory. Also, another reason why, or another purpose why we follow this technique, because this allows us or gives us the ability to fabricate the provisional crown or provisional restoration in laboratory. And then the master cast was generated, and I waxed up post and cores number 22 and 27. Then I sprued, invested, and cast in type 3 gold. And on the previous model, I made a 6-unit provisional FDP using PMMA alike. After that, the post and cores were cemented and adjustments made intraorally. During that, when you're cementing post and cores, you want to use a material that is dual cure, because there's no way the curing light will reach the bottom of the canal. That's one thing. The other thing, you want to use a cement that has a very thin layer thickness or has very low viscosity. In this, I used Ketac Sim, which is a resin modified glass ionomer. And then radiographs were taken to evaluate the amount of apical gutta percha seal, and it shows that we have about 4 to 5 millimeters of apical gutta percha seal. Then the provisional restoration that I fabricated in the lab was cemented in place, and then the occlusion was adjusted. So now the next step was to prepare the mandibular posterior teeth. So the mandibular posterior teeth were roughly prepared there, and during that appointment, I made a quick PVS impression in order to fabricate my provisional restorations in the lab. And I made my provisionals with PMMA alike. I splinted teeth number 19, 20, 21, 28, and 29. I made sure that I keep well-fitting margins and cleansable gingival embrasures for this patient. So this is how everything looked at the end of that appointment. So now the next step is to prepare the maxillary anterior teeth. I finalized or prepared the maxillary anterior teeth, and I made 6-unit splinted provisional restoration with integrity here. It made it chair side. Finished it, polished it, and stained it, glazed it, and then cemented it in place. And this is how everything looked at the end of that appointment. So now that I'm happy with the incisal edge position, with the aesthetics, phonetics function, and that the patient had some time to test drive these restorations without fracturing them, without developing any symptoms, I was comfortable to move forward and proceed with finalizing my restorations. And in this case, I decided to finalize the maxillary and mandibular posteriors first. So I brought the patient back. I finalized the mandibular posterior teeth. I placed the margin where I want to be, refined it with rotary and ultrasonic instrumentation. And then a PVS impression was made using a custom tray. And the laboratory work was done. And here we can see the mandibular master cast with sectioned and trimmed dies. So for the maxilla, in order for me to finalize or make the impression to finalize the maxillary posterior restorations, I needed to evaluate the peri-implant soft tissue and the ovate pontic areas. So with this presentation, I was comfortable to move forward with my final restorations. But what I needed to do is to transfer the soft tissue to the master cast to help us position the margin of my customized titanium abutments. And as you can see on the left-hand side, I transferred that to my maxillary master cast. And now that I have acquired both maxillary and mandibular impressions, I wanted to mount the master casts. And therefore, I fabricated a Lucia jig at the established occlusal vertical dimension. And then I sent everything to the laboratory to fabricate my final restorations in monolithic zirconia restorations. Also, we can see that the maxillary posterior implant supported restorations are cement retained. And this is the view of the maxillary and mandibular posterior restoration after the cementation. And this is an anterior retracted view of my posterior restorations in place. So after that, the maxillary and mandibular anterior preparations were finalized. The master impressions were made. Casts were mounted and sent to the laboratory for fabrication of my final restorations. And here I chose to use layered zirconia restorations for the maxillary and mandibular anterior region. Also, one thing to note here, it is important to document the contours of your anterior restoration or your anterior provisionals with photos, with go-by casts that you send to the laboratory so they can replicate the established aesthetics in the final restoration. And here, the maxillary and mandibular anterior restorations are bonded in place using APC protocol, air abrasion with aluminum oxide, prime with MDP, and cementing with resin cement. And this is how everything looked from the anterior retracted view after the cementation of the anterior and posterior restorations. And this is how everything looked from the extraoral view. So in this case, I definitely learned a lot of things. I made a lot of mistakes that I learned from. If I go back in time, there are so many things, many sequences, workflows that I would do differently. Probably I would address this case digitally. I would sequence it differently, but I'm happy it worked out and it turned out the way it is. It wouldn't have been the way it is without help or support of my program director, Dr. Bellis. His guidance and his help with this case was definitely tremendous. So this is the end of my presentation, and again, I would like to thank Dr. Uvoh for giving me the opportunity to present this case today and present this vital topic, and we'll be happy to take any questions that you have right now.
All right, thank you, Dr. Alkanderi.
Thank you very much.
Pretty, very, very awesome case. I mean, for me, I've been just looking at the literature. I think this is going to be made available to everyone on demand, so that you can go back and take a look. I think this ought to be in your library, because you're going to be having cases like this. This is what we do as dentists, and we see cases like that. Dr. Shrivastava, are you there? Dr. Boateng from Ghana, he says that how do you manage? Hold on 1 minute. Let me see if I can find it. How do you manage folks who develop TMJ problems while you're doing that?
You mean when you reestablish or open their occlusal vertical dimension?
If they have TMJ problems in addition to tooth wear.
So in this case, what I did first is, let's go back to that step, and that was the first step, which is placing a implant-supported provisional restoration on the posterior teeth in order to test the new position and test the patient's tolerability to the new position to see if he's developing any symptoms. Before I wait, where the literature shows that we wait 6 to 8 weeks, and I waited that period before doing anything that is irreversible. So I made sure that before preparing any of his teeth, I tested the new position. The other way to do that, we can place him on an occlusal guard to test the established occlusal vertical dimension. We put him on an occlusal guard at the new position and have the patient wear it for as long as possible during the day to test that position. If they develop a TMD, honestly, I will refer them out to oral medicine specialists. Yes, there are documented cases in the literature of those who develop TMD after opening their occlusal vertical dimension, but that percentage is pretty low. Okay. So there's a question: how did you determine how much you wanted to open the vertical dimension? And the length of the anterior teeth, again, the facially generated treatment planning way that's talked about or discussed extensively by Dr. Spear and now by Chris Coachman. The anterior teeth, the position of the anterior teeth determine how much we open their occlusal vertical dimension. So we put the teeth in a correct position relative to the patient's face, and then we design the occlusion or build the posterior teeth accordingly.
All right. There's another question here. Was the relationship between was there a relationship between the mandibular tori and tooth wear lesion?
Okay, one thing that I don't think there's a relationship between the mandibular tori, but one thing that I could think of is that the mandibular tori could be retruding the tongue, obliterating the airway, and there is some airway component causing his Brexism. That could be a reason that relates the presence of the tori to his Brexism. So that there could be an association with that.
How would you answer that question? What do you think somebody who wants to, a general dentist who wants to start managing this kind of cases?
Honestly, as a general dentist, I would not attempt a case that I'm not comfortable doing. That's why that's why prosthodontics is a 3-year specialty, because there is limits to general dentists what they can do unless they have the knowledge, the training to do so. Honestly, I'm not familiar with courses, but I'm sure there are some. if there is anybody from the audience that is familiar with any courses that can provide you with that type of training, please go ahead and share that with us. But honestly, speaking of myself, when I was practicing as a general dentist, I did not have the knowledge, the confidence, the training to address these type of cases.
Yeah. Sorry, Ahmad, I just want to add to that. There are courses, even in United States, depending on where you are.
I know there's the SPEAR course, there's Dawson course.
Yeah, there's Dawson courses, there's the LVI courses, all of those exist, but exactly what you said, I think none of these courses will provide you as comprehensive an understanding as a prosthodontics residency would. So treating a case, if this is something that really, really interests you, really considering a prosthodontics residency is the smarter way to go about it, because the amount of financial and time you will need to dedicate to CE courses to get to the same level as somebody who's done a prosthodontics residency is going to be a lot more than just going through a residency. So that's something to really consider.